So, good afternoon, good evening, good late night, depending on where you are. There's some big news in the cardiovascular prevention world. The FDA in the US has recently approved a drug for cardiovascular event prevention. The drug is an old drug, it's been around forever. And it's sort of not news if you've been watching our channel. It's colchicine, low dose colchicine. And we've covered that. What, Jesus, did you say it was the first time was 5 years ago?
5 years ago.
And we're going to cover it again. We're going to talk a little bit. We're going to talk a little bit more deeply and go a little bit wider in terms of this whole issue of cardiovascular inflammation and prevention. It was very interesting. If you kept an eye on the cardiology global meetings, this was, do you remember when the CANTOS trial was? Was that about 5 years ago?
Let me verify. I just saw that.
The CANTOS trial, it was where they used a drug called Alaris or canakinumab.
You have it really good in your mind. 2017. Yes.
Okay, great, thanks. So, and they used it, and they got a decrease in heart attack and stroke. So you'd say, well, why? That seems like it would be a major breakthrough. Why didn't it become a big deal? Well, canakinumab it's a drug used. It's an orphan drug, meaning it was not used. There were not a lot of uses for it. In fact, it was used for a thing called juvenile arthritis. The cost was $250,000 a year, and it was an injection. So once you start hearing all those things, it becomes a little bit clearer why it didn't become a big deal. The other reason was it gave up as many deaths due to infection. Because remember, inflammation is not all bad. Inflammation is what our body uses. It's our immune system attacking something that's bad. So as we begin to get a little bit deeper in terms of our understanding of cardiovascular events and prevention, we do have to understand inflammation. That's, again, on this channel, we've been talking about it since the channel's been around. We'll end up doing some more content in this area. Just a couple of other introductory comments about it. That study, the CANTOS trial using canakinumab, the PI was a fellow who's been a big deal in this whole area ever since the beginning. His name is Paul Ridker. In fact, if you go back about 20 years ago, he and a friend of his, that also, both of them at Harvard, were looking at some trials, some cardiovascular prevention trials, like WASCOPS, which stands for, it's the West of Scotland trial. They looked at some trials like Jupiter. And what they found was it didn't really matter so much whether the patient had a high, or whether the study subject had a high LDL or a low LDL. What they did tend to find was if they were on statins, they tended to have a lower event risk. So they started saying, well, maybe statins are doing something, but maybe it's not lowering. Maybe the statins' impact or mechanism of lowering LDL is not really the mechanism. Maybe it's something like inflammation. And sure enough, they looked at some other trials. They began to set up trials specific to this area. And it became a really big deal. One of the things there's several things that grow out of this. For example, we don't recommend use of atorvastatin, brand name Lipitor. One of the key reasons is that Lipitor, even though it's the most popular of the statins, it's really more effective at lowering LDL. It's not as effective at inflammation, cardiovascular inflammation, especially if you're a female. Well, that's half of us. But even more so if you have diabetes or prediabetes, and that's like 80% of us. So there's a lot of very practical implications that come out of this understanding of the role of cardiovascular inflammation in cardiovascular event prediction. To get back to the cardiology community, the global cardiology community, it was interesting to watch the reactions when Ridker's CANTOS trial came out, showing that it prevented heart attacks, that canakinumab did. It was like, well, dang, we knew that cardiovascular inflammation was something there, but we never expected this to happen. And what do we do about it? In fact, if you go back, we've got an image. We'll be sharing it a little bit later in this series on cardiovascular inflammation. As far back as 2004, there was a cover story on Time magazine that talked about inflammation as a leading cause of many types of illness, one of them being cardiovascular disease, heart attacks. So, this thing about inflammation and cardiovascular disease is not something new. It's not something that we've been unaware of. It's just been something that the medical community didn't know what to do with, because still we've got cardiology magazines talking about, yeah, it's real, but what do you do with it? So, without getting too far into today's subject, which Jesus will be getting started with in a few minutes, we'll get into a little bit more discussion about what we have on the channel, and then we'll get into the short content for today, and then the long content, which is going to be the new developments in anti-inflammatory medications for cardiovascular disease. Jesus, why don't you take it away?
Sure. And just to complement, whenever we're seeing some scientific evidence, we try to look that on critical eyes, or and make sure that we're understanding the science behind it and methodology. And making research is not easy by any means. There's a lot of things that you need to be careful about, including some biases and how you select your population, what your methods are. And while you were talking about these challenges and the results with the CANTOS trial and other trials, to my mind came John Ioannidis, which I'm getting
Yeah,
better on pronouncing his last name. Ioannidis. Oh, almost there. I thought I was there. So you have covered that in the past. He you put a video on one of the most viewed articles on PLOS magazine or PLOS journal, where he was talking about how most research is it's just not right. It's not correct, and might come to uh, inadequate assumptions sometimes. So there are good trials on small journals. There are very good trials on big journals, but you also have those trials that the results are questionable on some, even in some of the big journals. Did you know? And before we start, this is just a quick thing. Do you recall that company called Theranos?
Theranos, for sure.
I
I
was
was
just
actually working with a group called Premise Onsite at the time that right before that blew up. And we had Premise Onsite had part ownership, 49% ownership by Walgreens. Walgreens and Premise, and I was their representative for the two groups, setting up some micro sampling for Theranos, which is, I'm sure you're going to say, was run by Elizabeth Holmes.
Yeah, and there's a good series called The Dropout. I believe it's an HBO. It's really good. It's really good, really interesting, and it's challenging because it's a good idea. That one drop idea was really good. However, there were some publications out there regarding the science behind it, and I was
Mm.
just reading that Ioannidis,
Ioannidis?
I had it on my mind. I thought I was going to do it right. So Ioannidis, was one of the first ones to question that. He's at the Stanford graduate, so he was one of the first ones to say, "Hey, this science is not correct. Apparently, it's more important to make some profit than really doing research." And with medications, that's something that you're going to encounter every time you see a publication that is backed up by pharma industry. So that's why whenever we're talking about science and we're talking about publications on the channel, we try to take a look at what else is in there other than just the conclusion from the authors.
Yeah, and I had made a commitment early on when I was attending one of these sessions, a weekend session on cardiovascular prevention, that a lot of people. There was a new at that point a new to me way of getting that information out there for free called YouTube. But I also knew that there were a lot of people on YouTube, just like there are a lot of doctors, and you know this too. Doctors, nurses, healthcare people are some of the worst epidemiologists, the worst medical scientists in the world. They just read a headline and assume everything's correct. And as you're pointing out, that's not at all the case. For example, one of them that always pops into my mind when you mention that is the headline saying that metformin causes diabetes. And the researcher, I think it was in Hong Kong in a diabetes symposium, and I couldn't believe they got through the judges. There must have been no judging going on. And the whole point was that researcher missed the point. She just looked at, oh, okay, you know what? I find a lot of people that have diabetes are on metformin. So metformin must cause it. And it's like, holy mackerel. Um, Need to think a little bit more deeply. And I know that you're trained in this space. I'm trained in this space. As part of preventive medicine training, you get a lot of focus on what's called epidemiology. And that's basically some of the core of what Johnny Anitas's article is. And that is, his point was most stuff that makes it through the publication gauntlet is probably wrong. So you really need to go slow. You need to analyze things, and you need to just keep using more of a drip method. Is this correct? Is this good evidence? Is this good evidence? Is this good evidence? Rather than trying to take any one study and say, oh, that headline says it all. Be very careful.
Yeah, and it's hard to make a recommendation based on one study alone. There are
Yeah.
usually multiple studies that's the way evidence works. You have somebody proposing something, and then you have another group of researchers trying to prove if that it's actually correct. Whenever you are on medical training, you're supposed to be reading a lot of articles. But as a resident, I can tell you sometimes you just have enough time to do the things that you have to do on your practice, as you are on that education system, and you have a lot of medical people, professional on healthcare, that will just read the abstract and go with what the author said on that article and take it for granted. There's sometimes it's just not enough time to go over these filters to see if the evidence is actually strong enough. But anyway, moving on. Today, the main topic is 7 early, unquote, signs that you have diabetes. We're going to talk about how diabetes and overall insulin resistance will express on your body. We know that there is a lot of symptomatic patients out there that they don't even know, or don't have any idea that they might have diabetes, but there are a couple of hints that can get you there. And we're also going to discuss how some of those signs, even though they're quote early, and you will see that on the internet, on some other places, they're actually appearing after a lot of years of dealing with insulin resistance. The short topics that Dr. Brewer has already introduced is this first anti-inflammatory medication for cardiovascular disease just approved by the FDA last month. We're going to discuss that a little bit more. And previous topics, if you are new to the channel, PrepMed is a channel based and focused on cardiovascular inflammation, prevention of heart attack and stroke, state-of-the-art prevention for heart attack and stroke. And Dr. Brewer has done this for a lot of years now. and we are really, really confident that this is actually saving a lot of lives. And one of those topics that you will see on the channel, last week we had Robert Lepore, who was sharing us his history on how he overcome a lot of challenges in order to be in a better cardiovascular health position. Five things you didn't know about fructose. We talked about nutrient supplements as well, and on the side of fructose is one of those types of glucose that you will find out. And some people will say an apple a day keeps the doctor away. Well, be careful about those types of assumptions. There's of course different types of fructose, and on that stream you will find more information. And previous to that, we covered the number one risk factor for Alzheimer's, which, no surprise, we're talking about insulin resistance, pre-diabetes, and diabetes. And you can find more information about that on that show. We have plenty of videos that you can go through to learn more about this space. We have been having a lot of success with new patients on the traditional Medicare field. We are actually expanding the team right now. We have a lot of patients coming on board. So if you would like to become a patient, just have to visit a website, and you can let your information over there for us. And there's a waiting list for the Medicare service, and we'll be happy to get to you. Um,
Let me interrupt and just make a comment. A lot of people have a perception that they will get a concierge level service with Medicare coming to our group. And the reality is that's not the case. If that's your expectation, it's probably not going to be a good fit. We are good at science. We have, even our direct pay programs are not so much concierge. They are much more about using the right kind of science and getting the right kind of history and doing what the patient needs, with listening to the patient, hearing what you need. We're not about being able to make appointments for you with other doctors, other medical providers. We're also not a mental health anxiety group. And a lot of folks start thinking about that, especially when they think about, oh, I can get this done through Medicare. We're cardiovascular prevention. We're really good science. We're not, we don't try to make our decisions for our patients. Though, for example, there have been times when over half of our patients that we even felt like needed some low dose statins said, I don't want to have a statin. We're totally comfortable with that. So those are the sort of things that you'll see when you come to see us. If your expectation is, oh, they're going to make my other doctor appointments for me, they're going to they're going to have somebody talk with me 2 or 3 hours a week about some of my own emotional insecurities in this area, those are really not a good expectation. They're not practical, and they're not really a good fit. So we'll be doing more information in this area as we develop a little bit more clarity.
Yeah, and what you can expect as well is state of the art prevention recommendations that you will not find elsewhere. If you, as Dr. Brewer just said, if you need prescription, if you need scripts for different testing that are related to this field, we're definitely going to be able to help you. Dr. Brewer is licensed in all 50 states, and we're gearing up with a group of nurses that are being directly trained by Dr. Brewer and that are really capable. And the practice itself is just growing on an incredible speed. And we do know that this information in YouTube is already saving lives. We have a lot of patients that are coming to see Dr. Brewer from the YouTube channel, but even if they are very knowledgeable patients that know a lot about this space, and even they are finding benefits and having this extra step of what else they can do to be on a better position and improve their health. So if that's something that you're looking for, go ahead, visit the website. We are accepting traditional Medicare. And if you are not on traditional Medicare, we also have options for a direct pay service for you.
So, Jesus, are you familiar with the YouTube content creator and marketer term FOMO?
I don't think so.
FOMO, fear of missing out. What I'm what I'm going to
Oh,
say is clearly going to sound like an attempt for FOMO, but it is what it is. We've got a very, very significant waiting list to come on board. We're taking we're taking on new folks as quickly as we can, new patients. Um, but here's the thing: we are not going to compromise the quality of the science, the quality of the medicine that we do, and how we define the quality of our patient experience. So, yes, we're doing what we can to grow, but we're going to grow appropriately with high quality.
definitely.
And I think the best, if somebody's interested, the best way to do it is just to go to www.prevmedhealth.com, right?
Yeah, yeah. Just click on. We recently made changes on the website, so by clicking on book appointment, you're gonna have a short summary or short form to fill out, and then you're gonna see the options that we have for you. Still, if any of those options are not working for you, we have more. So you just have to call to 859-721-1414. We have other options if those that are on the website are not working for you. Moving on, I'll let you talk about this slide. I think this is a personal experience of you.
So I thought we were going to have a picture of Mark
Oh,
Twain.
I thought
Oh.
about that. I'm sorry.
So there was a quote from Mark Twain that, and the quote was, "The rumors of my death are somewhat exaggerated." What has that got to do with us today? Well, I got a phone call. Uh, what was it? Friday night?
I think Friday night, Saturday night. Yeah.
And somebody said, Ford. And I was doing something, so I didn't take the call. And then he sent a text back and he said, Ford, there's a very disturbing tag on you on Facebook. And he gave me the name. It was Candace Casey. And Candace wrote, "Look who died, friends," and mentioned my name. So I called my friend and said, "Well, I'm going to quote Mark Twain here." And my friend's very well read, and he said, "Oh yeah, I know what you're talking about." So Mark Twain was in a similar type of situation. Somebody had created a rumor that he had died. So he was a great comedian and put out an announcement. Well, the rumors of my death are somewhat exaggerated. This statement from Candace Casey on Facebook was that I had been involved in a car accident and died. Haven't been in an auto accident in 20 years, maybe. And I'm certainly not dead yet. So if you see that, please just ignore it.
And also be careful. We talked about phishing scams.
Phishing, yeah. We
So
think
be
it's
very
a
careful
phishing.
what you click on. Yeah.
Yeah.
All right. So going back to the introduction for the show today, colchicine is that medication that the FDA just approved last month for cardiovascular disease, and they did mostly based on this fairly new article published on 2020, colchicine in patients with chronic coronary disease. So if you're not familiar with colchicine, colchicine is an anti-inflammatory drug that is extracted from a plant, the autumn crocus, and it has been shown that it has multiple effects on the body. One of those being decreasing white blood cell responsiveness and activity. So, on theory, it makes a lot of sense because we talk about how inflammation is an exacerbated response from the immune system. So by targeting some of those immune responses, it makes sense to think that it's going to decrease inflammation. On the Lodoco 2 trial, which is Lodoco is the brand name for colchicine, they report that 0.5 milligrams of daily colchicine decreases cardiovascular events by 31% relative risk. And you have talked about relative risk in the past regarding the statins. There's a couple of series of videos about that. And Dr. Brewer, as we mentioned, covered colchicine 5 years ago. There's another study on 2013, I believe. That's the Lodoco trial, the original one. And we found this out, and this study still has plenty of limitations, and there are other things to consider and to mention. We're not taking that 31% for granted. We think that it's worthy covering this topic further on the next shows, but don't be surprised if you start seeing this on the headlines, and this is being marketed like the brand new anti-inflammatory that is going to solve cardiovascular disease. I won't be surprised to see that.
In fact, that is what you'll see. And here's the difference. Unless I'm mistaken, they're talking about colchicine at 6 milligrams, and colchicine at 5 milligrams has been out there forever. So it's a typical big pharma move to say, oh, this is totally different. And the reason it's different is it's 6 milligrams instead of 5. Now, at the end of the day, how often have we used this? Very, very rarely. We've used it, but not very often. Why? Well, number one, significant major cardiovascular inflammation is not that common. Number two, by far, the biggest way to deal with cardiovascular inflammation is lifestyle. It's not a drug. But, that's not the first time we've heard that on this show.
Yeah, it's not that new. And if other thing, colchicine is being used a lot for gout, especially for gout attacks. But one thing you need to consider with colchicine, it has a lot of interactions with other medication. It is safe for what it's worth. I mean, that's why it's out there. But has a lot of interactions. It has interactions with rosuvastatin, and the margin for toxicity is just too small compared to other medications.
So what does it do with rosuvastatin, by the
liver? It's impacting the liver.
A liver problem.
Kind of what the fibrates do. Whenever you're combining the statins and fibrates, that
Right.
increases the risk of liver issues and rhabdomyolysis, which is breaking and destroying part of the muscle. And part of those particles from the muscle go to the kidneys and cause kidney damage. So that's kind of the risk that you might have with colchicine regarding others. Of course, it's not that common, but it's a risk to consider whenever prescribing colchicine.
So that's one of the common questions that we get. Well, you see a lot of use of fibrates, and I really don't use them that often because they're usually used in conjunction with some statins. They're used to decrease LDL. We don't focus nearly so much on decreasing LDL. We're focused on decreasing inflammation. So it's not that helpful in that space, at least the fibrates. Then you've got the same issue. Most folks that have cardiovascular inflammation already have some plaque. So they should be on a statin. Somebody that's willing to take a colchicine for cardiovascular inflammation was already usually willing to take a statin. So that's where you get into some of the challenges of just trying to say, okay, we've got a miracle drug. If we discover that you have cardiovascular inflammation, we're just going to give you this. That's the problem. And again, that takes us all right back to, well, what do you do? Lifestyle.
Definitely. So if Gilbert can keep us the water bowl, we'll go to the main topic for today: 7, quote, early signs, end quote, that you have diabetes.
There's good and bad to most everything. And quite often, the thing that makes you strong also makes you weak in some areas. Jesus and I, as we covered earlier, are very strong in terms of epidemiology, the science of medicine, where something works, how to look at it critically. That in and of itself is a strength, but it also creates a weakness. We're not so good at the easily quotable, the snappy title, the things that are, I've had my own relatives say to me, "Hey, my doctor knows about you and he thinks you're really good, but I have to tell you, I think you're like a politician. It's hard to understand what you're saying, and it's just tell me what to do." And it's like, that's, I'm going to give you some facts and I'm going to give you things that might help you understand that what you thought was a fact may not be a fact. But I'm not going to just tell you what to do. I'm not going to be your daddy. I'm not going to be your authority figure. That makes things a little bit muddy in terms of the message. And so Jesus and I both, we're self-aware at least. And one of the things we've talked about multiple times is this thing of listicles. Human beings like lists. They want to make it real easy. They want to say, okay, let me just find 4 things that I need to do and simplify it. So we saw this and we said, that sounds good. We've been wanting to do some listicles, and diabetes is a big, big deal for us. So we decided to take a look at that, and we ended up, Jesus, when he looked at it, said, well, these are not early. These are not early at all. They're late. But Jesus, I'll be quiet for a minute and let you talk about signs of diabetes.
Yeah, and we saw that Dr. Bruce shared that with me. This was published on Good RX Health. I'm not going to say names. One nurse and one endocrinologist published that on that website last year, and I can understand what the goal is to publishing like this. They're definitely having a better marketing eye to get people to see their content than us. That's for
Yeah.
sure. So I'll give them that. And of course, if you don't know that you have diabetes and you're dealing with any of those, well, it's better now than never. But the reality is that if you're dealing with any of these 7 signs of seven symptoms or signs, you're probably already way deep into diabetes and insulin resistance. So the first one is feeling very thirsty, and what happens is that if you're dealing with high levels of blood sugar, the body knows that that's not good. That's something that you want to avoid. And one of the mechanisms of self-defense is to taking out that blood glucose, that excess of blood glucose. And one way to do it is doing it by it's there on the number 2, urinating more than usual. So whenever you're urinating more than usual, you are dropping all of that excess of blood glucose. But you're not just dropping glucose. The mechanisms of the kidney make you that whenever you're dropping glucose, you're going to lose water as well. So when you lose water, you're going to have that mechanism of trying to recover that water. And the brain is going to tell you that you're feeling more thirsty, you need more water, and that's what you're going to get. The third sign that is related to that is dry mouth and skin, because whenever you are losing water on your body, you're going to lose it from the, let's make it quote, less priority places in your body, and that is your skin. So whenever you are dehydrating, you're going to lose water from your skin, and that you're going to feel that perception. So these first 3 ones, thirst, urinating more than usual, and dry mouth and skin, are related to the same mechanisms. Is your body trying to take out all those high levels of blood glucose through the urine and making you dehydrated. Now, this can happen chronically, this can happen from time to time, or this can be so severe that puts you out in the hospital. And according to the Mayo Clinic, you will need to reach levels of glucose of 180 or above to start developing these symptoms. So right off, just with that comment, you will find out how we're mentioning that if you're starting to feel all this stuff, you are probably way too deep into diabetes already. Um, A lot of stuff happens with diabetes and you don't feel a thing, or maybe you do. That brings me to the number four, feeling very hungry. So whenever you're dealing with high levels of glucose, you're dealing also with insulin resistance. And what that means is you have all this glucose going on in your blood. You are not able to get that to use it as fuel for your body. So that your body is still needing some sources for energy and it's not able to take that glucose that is in your blood. So that's why you are gonna feel the need to eat more to gain more nutrients and to use that as energy. What happens, this happens both with the thirst and when you're hungry. If you have poor diet habits and you're feeling thirsty, you're gonna go get a soda, and by getting a soda you're just gonna go into this vicious circle of getting more glucose that you cannot use. And if you're feeling very hungry and then you go over and grab some snacks that are high carbohydrate like your cookies or chips or whatever, still you're gonna be promoting this vicious cycle of having a lot of glucose that you cannot use. Not having energy is gonna make you hungry, and that's gonna leave us to the number five, feeling very tired. And you feel very tired because it's the exact same reason. There's a lot of energy needs that you are not able to grab from glucose that is just going in your body from here to there and not able to go into the organs and the cells where it needs to be done. It needs to be used to produce energy. What happens if you're not using blood glucose for energy sources? You're gonna start to burn some fat, yes, but also muscle, and that's gonna leave us to the number six, losing weight unexpectedly. So you're gonna lose water, that's gonna drop your weight. You're gonna lose some fat, but you're mostly gonna lose protein or muscle, and that's gonna make you lose weight, and it's gonna make you fragile, and it's gonna create. If you have ever seen a person with diabetes that is decompensated, you will find people that just look really, really bad. And at the beginning, they might think that losing weight might be a good thing. However, if you're not doing anything to actively losing weight healthily, in a healthy manner, you're gonna end up in this place. And the seventh one, this really, no pun intended, this really caught my eye. The number one, the number seven is blurry vision. Uh, if you're having blurry vision, that means that blood glucose is already damaging your nerves in the eye. That's not early at all. That's way too deep into diabetes and what we call diabetic retinopathy. So if you're already having blurry vision, uh, like Dr. Bruce says, be afraid, be really, really afraid, because you are just too deep into diabetes already. So those are the seven, quote, early signs of diabetes. Any comments before we move on to the next one, Dr. Brewer?
No. Can you believe that?
I don't. I thought you were going to mention something. And why are we mentioning this quote thing? Most people with type 2 diabetes experience delays in clinical diagnosis for 4 to 7 years following the onset of hyperglycemia, or whenever you start having high levels of glucose, you start having damage, and you might not meet the criteria for diabetes, but you're still getting damage. This was published on Diabetes Medicine in 2018, and in this study, 80,000 adults with first elevated A1C. Out of those, whenever they went into the screening for diagnosis, 32.2% remain undiagnosed 1 year later. Now, that brings us to the concept of they were considering A1C as first a diagnosis criteria for type 2 diabetes, and we're sure that 32% is just 30% is just it ends up short to what the number really might be. We know that it's up to 70 to 80%. We covered that in a couple of other articles on pre-diabetes and diabetes.
Could I
Uh,
make a quick comment before you go into this?
sure.
Um, Number one, I was going to mention A1C and forgot that, yes, we have that slide, and you're getting ready to go into the misuse of A1C for diagnosis of this problem. The other point that I wanted to make, though, is if you just go into Google Scholar and start looking for what portion of people already have retinal disease of the eye or nerve disease by the time they get a diagnosis of diabetes, you realize it's not all over the waterfront. It usually tends to be between 1 and 2/3 of people. So that says two things. One is we're not diagnosing diabetes early enough. And the other is maybe we should reconsider that diagnosis anyway, because probably this tissue damage is happening before you reach full diabetes. So we've got some changes that we need to make in this area. If you want to prevent damage to your arteries, damage to your nerves, damage to your eyes, don't wait until you've got a formal diagnosis for diabetes, because it will already have happened. Here's one
Definitely.
of the reasons. I'll hand it back to you to talk about the mistaken use of A1C for making the diagnosis.
And I didn't intend this to be another listicle, but it might as well be
See
these.
there, well, you were doing a listicle and you didn't even think of it. You didn't even know.
Yeah. Let's say 7 things that the American Association of Clinical Endocrinology say about A1C for diagnosis of diabetes, right? So let's go to the very first one, and I think this is the first the one that has been misinterpreted probably.
Let me
A1C.
interrupt one more time.
Go ahead.
Um, Oh, I'm sorry. Go ahead. I'm not going to interrupt. Maybe I'll do it a little bit later. Well, no, I will. So, so here's the thing. When you talk to doctors about, just go ask your doctor, how do you make a diagnosis of diabetes? And what's the doctor going to say?
Probably
A1C.
A1C, yes.
But if you actually go to the research, you look at the evidence, how do doctors really make the diagnosis of diabetes? Something happened to pop up on a fasting glucose, and they happen to see a really high fasting glucose. So we are not only does the medical community not know how to do it, they're still too theoretical, and they're not even doing the way that they think is right, which is wrong anyway. So we've got a lot of ground to cover. We've got a lot of improvement we need to make in managing tissue damage and preventing tissue damage from diabetes. I'll try to be quiet now.
Let's go to the number one. A1C should be considered an additional optimal diagnostic criteria, not the primary criteria for diagnosis of diabetes. So that one should be repeated, posted, marked on the wall. Uh, just remember that A1C helps. However, we have a lot of patients that have normal A1C, normal fasting blood glucose, and still are dealing with diabetes. Now, the AACE and the ACE suggest number two, AACE and ACE suggest using traditional glucose criteria for diagnosis of diabetes when feasible. So there are conditions, and still, if you're having a fasting glucose over 126, definitely that's diagnostic of diabetes. Number three, A1C is not recommended for diagnosing type 1 diabetes. There's even the physiopathologic component, or the way diabetes impacts the body on type 1 diabetes versus type 2 diabetes, is vastly different in some cases or in some components. Number four, A1C is not recommended for diagnosing gestational diabetes. Guess what we use for gestational diabetes? Oral glucose tolerance test. So that's something that has been used and accepted for gestational diabetes. However, is not as mainstream used for type 2 diabetes on other populations. Number five, A1C might be misleading in several ethnic populations. For example, African American patients. We know that anything that affects hemoglobin, which is from where A1C comes from, anything that affects hemoglobin, including genetic predisposition or conditions, will affect A1C. Number six, A1C might be misleading in the setting of various hemoglobinopathies. Again, if your hemoglobin is sick or you have a hereditary component that makes your hemoglobin different to the general population, A1C is not going to help. And the last one, number seven, the AAC and the ACE endorse to use the use of only standardized, validated assays for A1C testing. Of course, there's some quality components regarding how to measure A1C. So be careful about A1C. Now, trying to rescue a little bit this part of the signs and symptoms, I came up. I encountered another article. This is from the Indian Journal of Medicine. This is from 2014, and it was published in India. And they calling this warning signs of diabetes. So some of those might be repeated, but I would like to rescue some of the other ones that are not as late findings as the seven first ones that we just encountered. So these are 11. The number one, unexpected weight loss. We already discussed that. You're losing not just water, you're not having enough energy that you can use, and you're losing some fat, but mostly muscle. Number two, and this is very common. We already discussed that as well. Frequent fatigue. You are not using blood glucose as energy source. You're gonna feel tired. But take a look at the number three, irritability. When I saw this number three, irritability, made me think about brain insulin resistance that we have covered in this channel multiple times. So as you find a stress on your whole body on not being able to metabolize glucose properly and dealing with insulin resistance, and that is going to impact the brain as well. And it has to do with insulin resistance. It has to do with hunger. It has to do with fatigue. Number four, repeated infections, especially in the genital areas, urinary tract, skin, oral cavity, and delayed wound healing. So we have mentioned as well how you had a couple of guests on the show talking about periodontal disease and gums inflame and tooth cavities and stuff like that that can be derived, and one of the main reasons that happens is insulin resistance. Number five, dry mouth. We already discussed. By dehydrating, you will get to feel this on more severe cases or when it has passed a lot of years after the onset of hyperglycemia. Number six, burning pain, numbness on your feet, which is also, this one is a late sign as well. Just like the blurry vision with the eyes, burning sensation and numbness on your feet is damage to your nerves now on your legs and feet. Seven one is itching, that can be related also to damage to the nerves. Number eight, reactive hypoglycemia. So that one can be one of the earliest stages. Whenever you're having peaks of glucose, your body is sending lots of insulin, and that insulin is still working, but it's overreacting or overworking, and you will see drops and hypoglycemia. And this is similar to the dawn effect on the mornings as well. Number nine, acanthosis nigricans, which is the presence of velvety dark patches on the neck, armpit, groin, which is an indication of insulin resistance. You can see that on the neck of this patient. And this one is kind of early. And the reason behind that is the insulin is promoting the function of some cells in the skin that are creating melatonin. I'm sorry, forgot the name for that one. It's not melatonin. It's oh gosh, I forgot the name of this. Do you remember the name of the protein that is giving the color to the skin?
Uh, so it's not melatonin?
No, it's not melatonin. No.
Hmm. That's what. That's.
That's basic. That's basic, and I always forget the number of the name of that.
Well, I'll tell you what, it's very therapeutic for me to see a young person like you having a senior moment.
It's very similar to melatonin, and I'm pretty sure that somebody on the chat is gonna remind us of that
Melanin?
one. Melanin. Thank you, Nurse Viv. Appreciate that. That's basic. That's basic. Medicine 101. I just forgot. But yes, insulin
It's
is
not
gonna.
melatonin. You and I were
No, it's
both
not.
going down the wrong path.
Yeah, that's a
Thank you,
different one.
then we're getting a
Ner-
lot of it now. Peggy
yeah,
and Marlene and several others.
yeah. Thank you so much. So insulin is gonna promote the creation of more melanin on the skin, and it's gonna create
And
these
thank you,
patches. And this is,
Dr. Vega, for demonstrating senior moment at your age.
yeah, I'm not too happy about that. I can tell you that. But this one, I think I would like to highlight this patches on the skin, because I have had patients that come to the clinic or to come to my office, and they say, I just have this. They go to the dermatologist, and I have just this patch on my neck. I've been scratching that. I've been washing it as hard as possible, and it just doesn't go away. And no, and it's not going to go away with soap. Number 10, decreased vision. And number 11, we have covered this as well, erectile dysfunction. Sometimes everything starts to make sense whenever you're starting to feel erectile dysfunction, and they go to heal that and to get an answer for erectile dysfunction, and end up knowing that they had diabetes and didn't know. And the last one, this is the last slide for today. We can go to the Q&A. This is from the American Diabetes Association. It's published on diabetes care last year, and is the criteria that is standardized on the guidelines to diagnose diabetes. And I think uh, probably here Dr. Brewer is one of those who are using this criteria on a more efficient way. Because if I tell you my experience on diagnosing diabetes before joining PrepMed, I was reading this like literally, not using OGTT at all, basically, just like the standards of medicine out there.
Yeah.
And then you realize they are telling you a lot of things between the lines. So one way to diagnose this is fasting glucose of 126 or above, and this is your normal fasting glucose, and you're gonna get a lot of people there, but you're also gonna miss a lot of people on that. Then they're showing you the OGTT, but they are saying OGTT above 200 after 2 hours using 75 grams. So what happens there? If you're considering only the 200 after 2 hours, you're gonna miss a lot of patients as well. Definitely. And we have seen plenty of people peaking on 250 at 1 hour and then dropping to 186 at the 2 hours, or 107 or 150. If you just focus on this one, you're going to mislabel them as not diabetes.
And if you go to the CDC website, they're pretty clear about that as well. Anytime a 200 or above during the OGTT.
Yep. Yeah, and they are yeah, exactly. And it depends on what institution is going through this. The other one is A1C, 6.5 or above, and of course it has to be a standardized measurement, some quality components over there. And the last one, I think it's one of the major ones. In a patient with classic symptoms of hyperglycemia, high levels of glucose, or hyperglycemic crisis, and random plasma glucose of more than 200. And whenever you're getting an OGTT and you're peaking at 200 or more, I can assure you 100% that you're having any of those symptoms that we discussed. More than one, probably. And this is what the ADA says. They say type 2 diabetes frequently goes undiagnosed for many years. Even undiagnosed patients are at increased risk of developing macrovascular and microvascular complications. So Um, I don't know if you want to add something else. It might have been a good idea for me to bring out the CDC chart as well. I can do that on another moment.
Um, Not so much about that. I do have a comment, and I didn't want to interrupt you because I had promised that I would not. And it was hard for me to not interrupt again. The one comment that I did have was it's a pop quiz for you. It's a guess what I'm thinking, but there's reality to it. You know, on the American Association of Clinical Endocrinologists, when they say problems with relying on the A1C, when you look at our patients, by far the most common reason for having a very low A1C, even though they are when they're full-blown diabetic, is not listed here.
Oh, they're low carb diet.
Yeah, there's so many people on a low carb diet these days. It's surprising that the AACE forgot the number one reason for having a low A1C, even though you might be full-blown diabetic.
Yep. And that leads us to patients that, and we have discussed that some patients that are having a difficult time improving insulin sensitivity, they are fine whenever they're still on the low carb diet, but whenever you challenge them, they're still seeing struggles on metabolizing carbs. So the real solution for them is just to stay on low carb diet. This is not a 6 months or 1 year lifestyle change. This is a permanent lifestyle change. If your body is not dealing with glucose properly, you're gonna have to make changes. And
GLR is saying, and by the way, GLR has one of those little insignias saying that he or she is a member. So your member Nazi thing.
you're making me look like how do you call that, a tyrant, something like that.
Yeah, the member Nazi, like the soup Nazi. Has a good point. He said it's so interesting how somebody with a lovely A1C like 5.0 can have a really sketchy OGTT where glucose stays way too high at 1 and 2 hours. There's no question. And again, that just underlines the value of lifestyle. The majority of our folks that can get really high glucose values, 250, 300, 350, rarely, when you look at their CGM for the month, rarely go over 120. And they have these great A1Cs, and it's lifestyle, managing that body content, minimizing fat, and not eating carbs on a regular basis. So that gets to the point where, Jason Fung, he says that all the time, and I quote him a lot. He says you can cure diabetes. Well, you're not really curing it. It depends on how you define cure. You're clearly taking the risk of diabetes off the table. But if you go back and you fall off the wagon and gain 50 pounds back and eat a lot of carbs on a regular basis, you have not changed the shape and the responsiveness of your insulin receptors. You've just removed the offending agent. What has happened is that carbs have become a poison for you, and you're just avoiding the poison. So thank you for your listicles today, Dr. Vega.
One of them wants a purpose, the other one just happened to be on the way. If we don't have anything else to add, let's then go to the Q&A. We have a set of really interesting questions. So,
I'm going to interrupt again and say, hey, we only have pictures of me on those transitions. We need to start getting some of Dr. Vega up there. What do you think of that?
That will be a good idea. I mean, it's your channel still. It's your name they're going after. Uh, I would love to see, and and I know I'm pushing a lot on this, and we don't have enough time just to go into that space just yet. But this the Spanish version of the PrepMed channel, I think, is gonna be a hit as well. Hopefully,
Big
and
deal.
and
Huge issues in
you'll
that.
find my pronunciation way better in Spanish than English. I can tell you
And you'll find my Spanish way worse than your English.
that. Let's start here with Peggy Douglas. Good morning from Fairhope, Alabama. Thank you so much for joining. I hope the content was good for you today and that you enjoy that. I know you answered a couple of questions. I'm gonna overrule just for now. Go to the ones who are subscribed, and then we can go back to those questions. Uh, Peggy Douglas, that Facebook has been going on for a while. A lot, some people has already received that, so yeah, be careful about that. Good morning, Jerry R. Let's see, GLR. Uh, Talking about the criteria from the probably the ADA or the AAC for diabetes diagnosis, and those criteria seem to ignore the flip side of the coin, hypoglycemia. Yes, and we mentioned that in one of those listicles, right?
Hmm.
Can you have diabetes if you're
Bingo.
having low levels of blood glucose? Yes, definitely yes.
You tend to see that with endocrine problems. You see that with thyroid as well. Hypo or low thyroid is almost always preceded by hyperthyroid. It's called Hashimoto's, and it's where you get inflammation of that gland and release of too much thyroid hormone. We tend to see that with a similar process with the pancreas. They used to be much more in touch with hypoglycemia and seeing it, especially among young women. But then 30 years ago, back when I was a young doc, the current or the wisdom at that point was that that was an old wives' tale. Well, now that we're actually getting CGMs available and doing more OGTT, it's becoming really clear that yes, overactive insulin levels and hypoglycemia is clearly an early phenomenon of this problem.
And GLR mentions as well, and insulin levels are nowhere to be found. Yes,
Right.
exactly right. And there's a whole
Thank you.
book from Dr. Kraft about that. You're trying to identify insulin resistance, and you're not measuring insulin resistance at all. And there are some of their methods. I'm gonna go to that route. That probably is a good bunny hole for you, Dr. Brewer. The HOMA IR testing, which is based on fasting glucose, and they made a good thing on measuring insulin, but it's still fasting insulin. And we have
It
seen
is.
plenty of patients on with normal fasting glucose and fasting insulin that are still diabetic. Uh,
And you knew I was going to go ahead.
yeah, go ahead. Yeah.
And you knew I was going to react to it because I have a problem with it. So many people say, "Oh, I'm all that and then some." I do the real thing. I do HOMA IR, and as Jesus said, HOMA IR has, and you tend to see that with folks that are a little bit more academically oriented and want to ace you in terms of I know the academics and they really don't. And HOMA IR was used in academic circles and still is. But it's, as Jesus said, it's nothing but fasting glucose. And until you actually get a moving picture, fasting glucose alone can be very, very deceptive. Get a moving picture, get an OGTT, and then you'll understand. Better yet, as GLR's pointing out, get a insulin survey, not just an OGTT. Find out how much insulin is required to maintain the glucose levels that your body's actually achieving. We will tend to see 15% pick up 15% more problems when we're actually looking at how much insulin is required to manage the glucose.
Definitely. And GLR mentions as well. If you don't mind, I'm skipping all the melanins that everybody brought out to me. Thank you so much. I think I was able to see one of those before we had a full chat, a chat full of melanin. GLR, it is so interesting how someone with a lovely A1C like 5 can have really sketchy OGTT where glucose stays way too high at 1 or 2 hours. Yeah, definitely right. And we went through the discussion also about the carb loading and preparing for the OGTT, which the ADA recommends. And I even in the I don't know if Kraft mentioned something about that as well. But the evidence is not showing that low carb diet is really causing those high OGTT levels itself. We lean more on thinking that it's just a high insulin resistance problem that is still going on.
Could I respond to that as well?
Sure.
You and I, we get this all the time. We'll start telling a patient, what's the evidence, what's the science behind something like this? And you just did that. You said there are some groups, there's sort of an urban mythology out there that you have to do a carb load before you get an OGTT. Or, some people will say you'll get an artificial diabetes. Others will say, no, that's not the way the mechanism works. It works just the opposite, and you'll get a reading of no diabetes when you actually have it. And there's obvious mechanisms behind either one. When you actually look at the evidence, it doesn't support either one. So then patients, once you get through talking about, well, what's the evidence? They sort of look at you and say, well, what would you do? And here's what I do. I don't carb load. And I have seen plenty of stuff on my OGTT. I'm 66 years old. I was 9.5 pounds when I was born. We thought that meant you were a healthy baby back when I was born 66 years ago. But now we're realizing every ounce over 8.5 pounds is an increase in risk for having diabetes when you get older. And my brother and sister, who were born 6 and 7 years older than me, were both 2 and 3 pounds less than I was. So, I've got problems with glucose metabolism, even though I maintain a BMI in the low 20s, usually 21, 22, 23. And I'm not alone. You see that a lot. And I don't need to do any carb loading to show the problems that I have on my OGTT.
And if I can give you a personal opinion, a personal perspective that I have on that issue is, if you have been carb loading if you have been on low carb diet for 5 months, 6 months, 1 year, 2 years, and you're gonna have an OGTT, my personal perspective is, you want to know how things are right now? Don't carb load, because if you're carb loading, you're doing stuff that you haven't been doing for the last 6 months, 1 year, 2 years. If you want to have a real picture of what's going on with your body while you're carb loading, go ahead and have it with carb load.
Yeah.
Without the carb load.
And that's what we end up saying. We end up giving the evidence. We end up saying what we do. And then the question is, well, what should I do? It really depends on what you want to know. Do you want to know what it's like when you're carb restricting? Or do you want to know what's going on when you're not, when you're carb loading?
Yeah, exactly right.
And we can help you interpret it either way. And I will tell you, from what I've seen, I'm not sure that there's going to be a huge difference either way.
Exactly. Yeah, that's what I think. What I've seen is a slightly increase when you don't carb load, but I mean, it's 10, maybe 20 milligrams of glucose, and that's it. GLR, yes, to what Dr. Brew just said about low carb diet and A1C, even though I'm full on diabetic, and I believe that's your case, Dr. Brew, as well.
Right.
So, yes, absolutely right. Peggy Douglas, yet it's amazing how many LC experts taught their low A1C, but never talk about challenging their insulin resistance. Yes, you have a lot of that out there. We have a lot of questions and comments from Peggy. You see that icon next to Peggy Douglas? I'm the enforcer for this. Uh,
You like
just
that
become
term better, huh? The enforcer.
the
Okay.
enforcer. Become a YouTube member. We'll be happy to get to you. I know it's not a money grab. We're just trying to make sure that we have questions that are getting answered, because on the Q&A we always have questions that are not getting answered. And also we have new patients, new people, new viewers sometimes that come here to see the show, and they drop their question at the very end, and so we never get to see them. So go ahead and do that. Amazingly hard to get an OGTT with insulin survey done right. Good, got it, but only after 2 hours fighting with LabCorp and doctor's office to get the right test order. I see lab orders all the time, and I can tell you, LabCorp doesn't have your traditional uh, fasting 1 hour, 2 hour measurement. They only have the fasting and 2 hours. For LabCorp, in order to get that, you will have to do what Peggy just did. And even with Quest and other labs, you have to make sure that measuring both glucose and insulin each time, because sometimes they measure insulin 3 times fasting, and they report that as 1 hour and 2 hour, and we know by the results that those are not the 1 hour and 2 hour insulin values. So yeah, technicians are not familiar with this test.
Jesus, I know you've heard it 1,000 times, but this is not for you anyway. It's for folks that might not have heard it on the channel. This happened to me. Our most common problem is, or maybe it's the most common problem. One of our most common problems is that we'll get the insulin survey back and it's 10, 10, 6, and 10. And it's like, that makes no sense whatsoever. And the reality is, it often isn't making sense. And it's because the insulin levels were all drawn at one time. You should draw both an insulin and a glucose fasting at 1 hour and at 2 hours, unless you're doing something more like the Kraft protocol, in which case you're doing fasting half an hour, 1 hour, 2 hours, and 3 hours. So I was doing I happened to be in the lab, our lab that we used, the lab draw site that we used in Alabama last year. And I thought, you know what? I'm going to go ahead and get the Kraft profile and be able to talk about it a little bit more on the channel. Well, I'm talking about it on the channel, but not because not because of why you might think. I got distracted on the phone and doing some work. And the third blood draw, I looked down and she had filled one regular tube and 5 small tubes with that third lab draw. And I asked her, I said, what are the small tubes? And she said, oh, that's the insulin. She said they had me draw them all on the third time. And I went, what? That makes no sense. She said, yeah, you're right. That makes no sense to me either. But I just called the lab tech help desk, and they said, no, draw all the insulin at once. And it's like, my nonverbals are telling you, it's very difficult to get recurrently good quality out of any of the national labs. I've had that problem ever since I went into medicine. As you may know, I've done organized medicine, national based health groups forever. And lab tech quality has always been a bane of our existence. It still is. And when you look at it, you understand why. The first time I had a Baledanine lab set drawn, they got half the labs. I could tell from talking to the folks. I was going to an event in Vegas, so I just went by a local Quest site. The lab tech came in late. Their routine lab tech was not there. They had just gotten somebody that decided to come in and help them, not well trained. And that's what happens over and over and over again. In addition, you have other reasons for having quality challenges. If you've seen one lab site, you've seen one lab site. They call themselves a national company, but it is a real struggle. Pardon me for the rant, but it's something that our folks need to know. These are critical. We wouldn't do these tests. They're a headache, and you have challenges in terms of getting the correct information. The reason why we do them, we wouldn't do them if they weren't so valuable. The information is so critical when it's even when it's not done right. Most of the time, you can get critical information out of this, as in 95, 98% of the time. It's worth 2 hours of your time to know this information.
And I was reading on the American Diabetes Association recommendations in diabetes care. Was just revisiting that document yesterday for today's show. They have a line down there about that part of the OGTT, and they say we don't recommend that because patients don't want to have that done. They don't want to spend 2 hours,
Yeah.
and there are challenges on the technique to get it done standardized. So they know the value of it, but the technical issues are driving, at least the ADA, driving them away to recommend that as a standard just because of that. But they
So
know
they
the value
did
of
just
it.
what we keep wanting to do. They threw their hands up and walked away.
Yep, and that's on the guidelines. You can see that right there. They
Yeah.
see those are the challenges. Uh, Peggy Douglas again. Thinking about the carb loading, I read dozens of articles in HA, PubMed, healthcare clinics about doing OGTT, and they all say you need to carb load. And I tell you why. I'll tell you why. All of them are referring to Dr. Kraft's book. Dr. Kraft was the first one to recommend carb loading on the book Diabetes Epidemic and You, and a couple of other articles regarding insulin survey. And I bet that's why everyone is recommending that. Also, a huge difference in triglyceride levels. Fasting 36 hours made it go up really high, but down next test when only fasting 12 hours. That's a really interesting question. Do you have any comment about that?
I don't. Other than I agree. I think that's very interesting. We do know that triglyceride levels do tend to be less stable and more responsive to this. So that may be a reason to carb load just in and of itself. Looking at trig levels.
I have a guess for that. I think it has to do with gluconeogenesis. I think
Hmm.
whenever you're fasting and you're still having insulin resistance and you're still having that mechanism driving you to glucose metabolism, your liver is going to create more glucose. And in order to create more glucose, sometimes it needs other resources. So the liver itself can create triglycerides out of fatty acids. So
Yeah.
I think it's during those periods of time that you will see, and I will say this is a transitional increase in fatty acids and triglycerides, just to grab them and use it as energy fuel as well.
To me, there's no question that, or that's clearly an obvious potential mechanism. The real concern, though, is when you go back and you compare those levels in terms of cardiovascular risk, which ones are the correct ones for comparison? Comparing that to the evidence about cardiovascular risk that's out there.
D. Dutton, methionine increases homocysteine, which reduces endothelial function through impaired dilatation from oxidative stress and thus nitric oxide. Considering a future talk on methionine and homocysteine, and I believe you did answer that. And I do have that on my topic list. We have a topic list for next year already. And we
We're
have
into next
methionine
year.
and homocysteine. Yeah, we have a list of topics for topics we have. Topics we have are right there, and homocysteine and methionine are right there. JMK 2921. With regards to nutritional epidemiology and cardiovascular disease, we just posted a video this week about that, so probably that has something to do with that. You were addressing how having exact information about nutrition is hard because you can't we only can rely on self reported surveys of people telling what they eat. Um,
Let me ask you. Today is Wednesday. Do you remember what you had for lunch on Monday?
no,
I don't either. And
Uh,
that is the essence of the problem with nutritional epidemiology. They're asking, they typically get information back for the past week or the past month, and most of us can't remember what we had beyond last night.
yeah, and JMK is making the point. Why should we pay any attention to these retrospective observational studies, especially when these studies are extremely confounded? And I think JMK has a point. However, I'll say there's nothing better yet. We don't have anything else that's better. So that's why whenever we see those kinds of studies, we read them, we take a look, we see what's there that's useful, and we have critical eyes on them, and we know they are not the last word until they're replicated enough to have similar results elsewhere. Just Rusty, diabetes, smoking, and high blood pressure all raise cardiovascular disease more than lipids, according to the online calculators. Yet, my PCP's response is to lower LDL at the risk of um, rising insulin resistance. Am I missing something?
Well, maybe you are, maybe your doc is. I mean, we use statins as well. I think what just Rusty's referring to is the use of statins to decrease LDL. And that's the standard that docs tend to use because they don't know, it's just not that well known about cardiovascular inflammation yet. It will become known as we reported today in the short about colchicine and cardiovascular inflammation. We're making as a culture, a medical community, we're making slow but steady progress into that area. But if you're, 50 and 60, you don't want to wait the 30 to 50 years that it's going to take to get there. So now, having said all that, though, even we who don't really push that hard and worry that much about LDL levels, we do recommend use of statins, not for LDL levels, but for if you have plaque, and we recommend it for other reasons. We recommend it for cardiovascular inflammation. So Crestor and Livalo were the two that we used. We used to use some of the other ones, simvastatin, pravastatin. Those are good meds, but you have to worry about a genetic issue called KIF6. You don't have to worry about that now with these other two. Of the two, Livalo has no impact on glucose level or insulin resistance, but Crestor does. Now, in the low doses, that 5 per day or less, it really doesn't have a significant impact. So there's maybe a little bit more nuanced set of issues around that space. And for those of you that have been able to follow me through all of that, thank you for your interest.
Bart Robinson is saying, greetings, just like Gail and Kirk. And JMK has another interesting question, and it's related to that LDL discussion. You already answered about that. JMK, doesn't Dr. Paul Ridker still think that LDL is a major player in causing cardiovascular plaque formation? And your response, JMK, I think that depends on your definition of major. Ridker's definition of major and day of the week. It's kind of, are you saying like there's the same thing for him, right?
Well, part of the day of the week means, I think he, like many of us, goes up and down in terms of, okay, just how important is it?
Okay.
And I think he's changed a little bit on that space too.
So, bottom line, what you will say about LDL?
We've said it multiple times. LDL matters. So you can see that. I mean, if it didn't matter, the kids that are in their teens and 20s who have homozygous FH, familial hypercholesterolemia, LDL levels of 350, 400, you wouldn't be having teenagers with those conditions having a heart attack or cardiovascular events. But is it the big deal that most of the medical community thinks? Should we be focusing on that as the only priority? Not at all. And it's clear from Ridker's work, he doesn't focus on that as the only priority either. In fact, he is the guy that said, look, cardiovascular inflammation is the driver here, much more so than LDL. That's why, that's why he brought up the whole issue. When you do what we do, you expect to get a whole lot of folks with FH, and we do. And your typical heterozygous FH, familial hypercholesterolemia, they still tend to not have much problems. Yes, it may be an added risk, but not that much of one. When they start getting the other issues, and it's most commonly, just like for everybody else, they start getting into their 50s, late 50s, early 60s, they start developing unrecognized prediabetes and diabetes. That's when your typical heterozygous FH patient starts to show a problem. Now, again, what do I mean by heterozygous and homozygous? A homozygous is a patient where they got significant disease gene from both mom and from dad. In FH, there's actually 2,000 different SNPs, single nucleotide polymorphisms. Pardon the technical terms, 2,000 different genetic variations. So it's a little bit more complicated than saying that you just got one from mom and one from dad, but that's really the basic concept here. And those folks have LDL levels 300 and above. Your typical FH patient is a heterozygous, meaning they only got one, either from mom or dad's side of the family, not from both. And the kind of LDL values you'll see there are like 180 to 200, 250, that kind of thing. And those kind of numbers tend not to show, you don't see teenage deaths, 20-year-old deaths due to LDL at those kind of levels. As many of you may have noticed, I didn't go into the lean mass hyperresponder bunny hole. We had enough bunny holes.
A bunny hole in a bunny hole. Janice Jensen, should everyone be on metformin? I believe so. Unfortunately, I disagree. I don't think everybody should be on metformin. However, there are big benefits on metformin, and Dr. Brewer has mentioned a lot about how metformin should be over the counter. It is in Mexico, at least. In Mexico, it's over the counter medication, but there is a lot of over the counter medication in Mexico. So
you have over the counter antibiotics, don't you?
It's except antibiotics.
Oh, everything except antibiotics.
And some controlled substances. But you can get other medications like Prozac or antidepressants without a prescription.
Wow. And the water. But before you go on, let me ask you this question. So you're talking about TAME. Before you talk about the TAME study, I agree with you, but I'm curious about who you're thinking of. Who do you think should not be on metformin?
That's a really good question, because on my mind, I always think of metformin for glucose until I saw your comment on the TAME study. I don't think there is a major side effect that will keep you out of metformin. If you're taking that for aging, I might change my mind.
Well, I would clearly say your 12-year-old with no problems should probably not be on metformin. Even your 60-year-old, that's like 1% of the population, cannot get over the gastrointestinal side effects. They have severe GI side effects from metformin. I don't think those people should try to. A lot of them are able to take low dose metformin, and a lot of them choose to do that. I clearly don't think they should be on it either. I do think there is value behind the TAME study. It's targeting aging with metformin. It's a big deal. It was not developed by Nir Barzilai. Well, you can argue about how much of it was Nir Barzilai, the principal investigator and the fellow who's been on a lot of YouTube and social media talking about it. But you could also say, actually, maybe this whole idea was developed by the geriatricians at the National Institute of Aging. Here's the point behind that. They know that a lot of things that are, quote, the normal, what we consider normal aging are really undiagnosed diabetes and prediabetes. And so if that's the case, and we've got a medication, as Jesus is talking about, that's over the counter in a bunch of places and is really safe, shouldn't we think about using it more often? And I clearly think it should be used a lot more often than it is.
And I think we're going to go with the last question of the day. Just Rusty, speaking of bad headlines summarizing studies, Samson trial, 90% of statins complaints are nocebo effect. But when you read the study, the data was so corrupted, I'm shocked it passed peer review. So for those who might not be familiar with nocebo effect is similar to the placebo effect. And the placebo effect, you have people that have the benefits of the drug by taking just the placebo. And but the nocebo effect is patients who are advised about the side effects of the drug, but in the trial they're getting the placebo instead of the drug, and they still develop the side effects. That's the nocebo effect. And it's interesting. I never heard about the Samson trial. It will be a good idea to take a look at it. But if, like just Rusty says, the data was just corrupted and it passed peer review, that tells you a lot about the process. I can tell you myself, I've been a peer reviewer from some journal at some years back. First, you don't get anything for that. It's just, hey, do you want to do some free work for the journal for us? Journals they're gaining a lot of money. I can tell you that journals earn a lot of money with their publications. And if you want to publish something that is free for everybody, you have to pay as an author, so the journal publish that. If not, the journal is going to get some money from it. And peer reviewing, you don't get anything for peer reviewing. So you need, if you want to be a peer review, you have to be something that is very, very highly ethical and that is willing to give time for free for a journal to make profit. So that gives you an insight of what peer review might look like, and why sometimes research can be published without the accurate review process that might need to be done. That's
You
my
get a lot
version.
of challenges with peer review. Sometimes especially in a narrow field, the only peers that know how to review it are the peers that they select already know the other provider or the PI. They know that study. They may have some, they may feel like, I don't like this guy. I know him and I don't like X, Y, and Z. So they may come at it from that emotional perspective, or they may have the opposite perspective. I like this guy. Anything he or she does, I'm going to pass off on. You get a lot of that as well. Like you, Jesus, I've not seen the Samson trial. I do know there's a major, and we deal with that in most of our patient meetings, the concerns about statins. And here's a short version of the entire statin thing. Statins came out of the blocks. They did well. They became the most profitable, most used drug ever for many years. Biggest moneymaker for pharma. So pharma put a lot more advertising into it. They became overused. It became a simple, and it still is. Doctors oversimplify cardiovascular prevention. They make assumptions that patients aren't going to make the lifestyle changes. So they just say, okay, we're going to write you a script for a statin. Then whenever something gets popular, just like when Ozempic got popular recently, then it became the more popular thing to show, here are the problems with Ozempic face, with, here are you lose, Peter Attia saying you lose muscle mass with Ozempic. And same thing happened with statins. And the two big journals in England, medical journals, the British Medical Journal, BMJ, and Lancet, basically got into a publication war where Lancet was saying the statins caused too much damage, and BMJ was protecting it. At the end of, there is no end of the day on this. This debate is still raging. There was a lot of public health data that looked at this and basically did a fairly good review and indicated there was a huge increase in cardiovascular events associated with the tens of thousands of people that dropped their statin doses. Now, that may sound kind of weird coming from a guy who feels like there are too many people taking statins for the wrong reasons. But again, there's both sides to this debate, and both sides are making a lot of errors, I think. There's a lot of emotion around it. One of the things that you'll see, and I'm not surprised to hear some of the findings coming out of something like a Samson trial. I know that statin complaints tend to be over. True problems with statins are far less than the complaints that we see with statins. There's a huge amount of fear out there about them. But then you've got the other side of that debate too, because one of the strongest things that we say to doctors about statins is do not automatically ignore a statin complaint. You may hear it time and time and time again, and it may be a temptation to say, yep, that's another fear-based subjective statin complaint and it's not real. Statin complaints can be real. Treat them as real until you prove otherwise.
Definitely. So anything else to add, Dr. Brewer?
No, thank you very much. I think it was a great show. I appreciate your getting into the content world and giving us a couple of listicles topics.
I appreciate that, Dr. Brewer, as well. And thank you so much for joining the show today. We'll be seeing you next Wednesday. Thanks a lot.
And we'll be seeing you in a half hour with our next patient.
That's right.
We'll see you.